Thank you for joining today's Health Education and Learning Program webinar around the topic of the role of social determinants of health and value-based payment models during COVID-19 and evolving rural perspective. By attending this webinar, participants will be able to describe how social determinants of health affect the health and well-being of rural communities, illustrate how rural health providers and community partners address SDOHs during the COVID-19 public health emergency, and identify resources to support rural health providers and community partners to assess social determinants of health needs and track outcomes. The National Rural Health Resource Center is a nonprofit organization dedicated to sustaining and improving healthcare in rural communities. We are the nation's leading technical assistance and knowledge center in rural health, and we focus on 5 core areas: transition to value and population health, collaboration and partnership, performance improvement, health information technology, and workforce. Here at the center, we are committed to DEI and anti-racism, and we create an environment that reflects the communities we live in and serve, a place where everyone feels accepted and empowered to be their full, authentic selves and where everyone belongs. We encourage you to read more at our website with the link provided. With that, I'd like to welcome our guest speaker, Dr. Alana Knutson. Dr. Knutson serves as a program area director in public health department at NORC at the University of Chicago and is the director of NORC's Walsh Center for Rural Health Analysis. She has over 25 years of experience implementing and directing public health programs, leading health services and policy research projects, as well as evaluating program effectiveness. She has led projects funded by many federal agencies and private foundations. Dr. Knutson currently serves as the project director for the Rural Cohort Analysis of Rural Health Programs funded by the Federal Office of Rural Health Policy, for the Pennsylvania Rural Health Model Evaluation funded by CMMI, and project director of the Health Resource and Service Administrator Bureau of Health Workforce Substance Use Disorder Evaluation. She has state and national public health experience, having worked at the North Dakota Department of Health and for the Association of State and Territorial Health Officials. She serves as the RUPRI Health Panel and the Board of Directors of the Maryland Rural Health Association, the National Rural Health Resource Center, the Rural Health Foundation, and is a member of the University of Maryland School of Public Health Community Advisory Council and the ETSU Center for Rural Health Research Advisory Board. She received the 2021 National Rural Health Association Researcher of the Year Award. We are honored to have you with us for this hour, Dr. Knutson, and thank you for joining us. And I'm now going to turn it over to you.
I will share my slides, just one moment. Can everyone see my slides okay, Kiona? We're all good?
Yep, it looks perfect.
Okay, fantastic. Well, first of all, thank you so much for inviting me back to share some updates from the last time we gathered in July of 2021. There's been a lot of activity going on, and I am most grateful for all of the work that our rural health providers have done to support our rural communities. And I especially am appreciative of the rural providers who shared with me their experiences in meeting the needs of their community during this public health event. We've already gone through those. So where to begin? One of the first lessons that our rural health providers have told me is that we need to meet people where they are. And it's really important that during a crisis such as we've just experienced, we don't assume that we know where people are. And one of the places that we are most important for us to think about is to meet their needs. And how many of you remember Maslow's hierarchy of needs? I think most of our freshman psychology classes began with this in our psychology classes, where we look at the hierarchy of needs that people have. And if we do not have adequate air, clean drinking water, safe and affordable shelter, healthy food, we're getting some decent sleep, and we have clothing, especially for those of you, I saw some North Dakota colleagues and Minnesota folks online that have been experiencing some spring blizzards, and I think Montana folks as well. We need to make sure we have adequate clothing for those events. We also need to think about safety needs. Not everybody is secure in their environment. Not everybody has adequate employment. Not everybody has the resources they need, nor the access to health services to keep themselves healthy. And that third level, that love and belonging, I think we really learned, and we still are learning as the public health emergency has evolved, that social connectedness is so important. And when people experience long-term social isolation, especially some of our older adults, it really takes a toll, not only on their mental health, but also on their physical health. So again, coming back to meeting people where they are, they may not be at the same place prior to an event. And I would also remind you, it's not just public health emergencies. We all go through different disasters in our rural communities, be it tornadoes, hurricanes, fires, extreme drought. There are all kinds of different disasters and economic factors that really affect where people are. So keeping those in mind, we are going to talk about social determinants of health. And I'm just going to remind you that a lot of times people talk about social determinants of health as determining health. And I would like you to think about, these are things that may drive health. They don't necessarily have to determine your health, especially for some areas where some of the challenges are large. We see great progress made forward. So they're driving people forward in their health. So as we continue in our discussion, I want to share a couple of definitions that are often used to describe social determinants or social drivers of health. And the first one is Healthy People 2030. And that particular definition really speaks to the conditions in the environment where people are born, live, learn, work, play, worship, and age that affect a wide range of health, functioning, and quality of life outcomes and risks. The Robert Wood Johnson Foundation has expanded a bit on that and are very specific in speaking about the important roles that our schools, housing, good jobs, and safety play in keeping us healthy. The CDC has put together this great visual for us that really provide a nice high-level overview of what the social determinants of health entail, including health. Excuse me, one moment. I think I need water. This is my water need. Healthcare access and quality, neighborhood and built environment, our social and community context, economic stability, education, access, and quality. And specifically, these areas comprise these subcomponents. And you're going to hear me coming back a lot to the economic stability, because a lot of the things that are part of social determinants of health are really driven by the kind of economic base that we have, usually linked to our employment and income that we have, but also could depend on the types of expenses that we have. As we know, we see fuel prices increasing. A lot of people have different types of debt, including school debt. Some people have a number of medical bills and the like. So there are all types of different issues that we must consider when we're looking at that economic stability, which then also plays a role in the next line, the next one of neighborhood and physical environment. Having safe and affordable housing, as well as safe transportation, are very important, in addition to having access to places where we can go and recreate. Oftentimes, our education also links directly to our employment and our income, be it the training that we received in our vocational training or in higher education. All of these different types of educational experiences really contribute to how we are able to generate an income to sustain ourselves so that we can have food so that we can afford healthy food, so that we have access to healthy options. This fifth column, community safety and social context, again, is something that I think we really have come to appreciate through this public health emergency, that connection that we have to others, the importance of community engagement, particularly in our rural communities, that is so foundational to who we are, as well as recognizing the different types of stresses that many of us have experienced, be it as caregivers of family members or having our children at home for school. All these different experiences contribute to this particular social determinant. And last but not least is our healthcare system. Do people have health insurance coverage? Are there providers and pharmacy available to them? Are they accessible? Do they have public health? Do they have behavioral health, oral health? Do they have health that is respectful of their culture? All of these different components contribute to that overall health and well-being that is so important to people's longevity and their quality of life. I often use this slide when I talk about health and wealth, because to me, that wealth really underlies what we have in terms of our health. If we do not have health, we usually can't work. So health is foundational to wealth. And likewise, we need that income to be able to have safe housing, safe transportation, healthy food, and the like. I want to share this recent update from the US Department of Labor's Bureau of Labor Statistics. And I want to take you back to 2007, 2008, when we were in the Great Recession. And as you can see on this graphic, the bars for metro, which is urban, and the orange, which is non-metro, which is rural, we were at the same place of employment. We were at 100%. Well, what happened through that recession, we saw that our employment dropped. And what happened over the course of time is that our urban communities' employment not only regained and recovered to where the employment was in 2007. If you see that 2013 bar, urban areas were able to recover after those years, but rural has never recovered. And then if you go to the right side, you will see a major drop in 2020 when COVID-19 started. And you will see that for both rural and urban, we had a drop in employment, and then we had a slight uptick in 2021. But again, I want to point out, our rural areas have never recovered our employment from 2007, 2008 time period. So even though we have made some progress and we have made some recovery since COVID-19, we still are not at the level of employment that we were in 2007. And what does this mean when we look at race and ethnicity? This depiction, this graphic, shows the white columns on the left, and we have metro versus non-metro for the years 2007, 19, 20, and 21. And one thing you will see is that the unemployment for our Black and Hispanic populations in both metro and non-metro areas were higher in 2021 and 2020 for our communities of color. And although there has been some recovery and those unemployment rates have gone down, they are still considerably higher than for our white communities, both rural and urban. So what does this mean when we look at employment and all of these different issues? How can we get a good pulse on what does that mean and how does it translate for the people that we serve, for the patients that we serve? One tool that is used in a lot of our rural communities and for our rural healthcare providers is the Prepare tool. And this particular tool provides a quick assessment to be able to understand what social risks our patients are presenting with. And we can make assessments for personal characteristics. We can include money and resources, as well as what's happening with their families and home environment, how they're doing socially and emotionally, as well as tracking on other measures such as safety. And let me show you briefly, this is what a form looks like. And when I talk to a number of our rural providers, many of them, especially with value-based payment models that have been implemented, have now started using Prepare in their emergency departments as part of their EMR. It's embedded in their EMRs. Also, when I talk with different clinical administrators, both at rural health clinics as well as federally qualified health centers in rural communities, they are also using Prepare to be able to capture important information that helps them in better understanding how their patients are doing and what kind of issues might be affecting their health and well-being. This tool was especially important during COVID, and we still are seeing some real utility in this as a post-COVID tracker, if you will. And what's really unique about this tool is that we can collect information at that individual level when we do these patient assessments, either at the clinic or in the ED. And that provides us some really good information that we can also share with our community. We can also roll that information to be able to look at populations. So we can understand who is at greatest risk. And we can target then our outreach resources to make sure that we are reaching the people that can most benefit. For example, when we were working on increasing vaccination rates, we were able to identify those populations that were not getting vaccinated, and we were able to do some targeted outreach to be able to help them get access to those vaccines. And lastly, this information can be rolled up so that we can look from a state and a national policy perspective, so that we can learn the most important part of any kind of public health emergency or natural disaster is that we can learn from it, so that when this type of experience or something similar happens next time, we are even in a better position to not only respond, but to more quickly recover from the event. One of the things that we heard a lot about, and that a lot of our rural providers shared, was there was a lot of concern about rural food insecurity. Now, interestingly, rural food insecurity is not new to COVID, to this public health emergency. In fact, over 2 million households in rural communities face hunger. Rural communities make up 63% of US counties and 91% of counties with the highest rates of overall food insecurity. 86% of the counties with the highest percentage of children at risk for food insecurity are located in rural counties. That's a lot of counties. That's a lot of children. And rural Black people were 2.5 times more likely to be at risk of hunger compared to rural white, non-Hispanic individuals living in rural communities, with rural Native Americans having the highest rates of food insecurity of any racial or ethnic group. Excuse me. I also wanted to share that one of my colleagues recently published a research project on looking at food insecurity among our healthcare support workers, those frontline healthcare residential home workers, and found that almost 20% of those workers identified as food insecure. And the highest insecurity were among those workers who had children. So even when families are working and are full-time workers, there is still some challenges that we have in rural communities being food insecure. So how did our rural providers respond to food insecurity? And this is one of the things that I love being from a rural community. Rural providers, especially those that have really worked on their value-based payment models and they have care coordinators in place, or they have community health workers in place, and they have put together community resource guides and have really kind of made that, connected those dots of those important resources in the community. One thing our rural providers did was coordinate with local food pantries, and they coordinated so that those pantries would be open during the time they were doing COVID testing. They also provided all of the hours for the food pantry to the providers, so that should a patient present at a clinic or an ED and they needed food, they could be provided those hours so that they would know when they could get access to that food. Some of our rural providers also offered vouchers for food pantries when patients came for visits, while others worked with local harvesters to coordinate commodity drops so that there could be fresh produce available for patients who otherwise would not be able to access that food. Other rural providers shared that they were helping their patients enroll in WIC, that's Women, Infants, and Children, and SNAP, which is a Supplemental Nutrition Assistance Program. Both of these are supported by our U.S. Department of Agriculture and provide food support for women, infants, children, families, and individuals who need that support. And patients also, or providers rather, also asked if patients had any unmet needs when they were making appointments. Because if you do not have food, you need food now, not when you are able to make your appointment. And oftentimes the provider scheduler was able to make those connections so that the families and individuals could get food right away. Likewise, they were able to identify resources for families when children did not have access to receiving school lunches. And that was particularly important during those times also when children were quarantined, so that food could be either delivered or provided. I also learned that many of our rural providers, even though they were working so hard in supporting their rural communities, also helped coordinate food drives during holidays such as Thanksgiving and Christmas to ensure that there were extra holiday food baskets available in their communities. And others also noted that even some of the local providers in their community, some of the local businesses, even including dollar stores, stepped up and provided local access to milk, cheese, bread, butter, and eggs. When in the past, those types of products were not available. So again, community businesses worked with our providers, our rural providers, and identified what needs were, and together they helped to address those needs so that people would have access to food. There were also some challenges noted with transportation, and there were also some really interesting solutions by our rural providers. Buses were converted into vaccination and mobile clinics so that people did not have to get separate transportation to come to a clinic or come to a hospital to be able to get vaccines. Many rural transit agencies also stopped collecting fees, and they provided transportation for essential workers, and especially healthcare workers. And I know some healthcare administrators said that was really critical for them to be able to maintain operations, having that additional transportation available. Rural transportation providers also expanded the types of deliveries. For example, some of them took meals, including school lunches, to the quarantine students. They delivered prescriptions, they delivered groceries, they delivered medical supplies and other supplies to be able to help those people who were unable to leave their homes during the height of COVID. There are also some other considerations in transportation, and that is rural road safety. And one of the things that we often look at when we're looking at unintentional injury and preventable deaths in rural community is traffic fatalities. And in rural America, our traffic fatalities are 2.5 times greater than urban traffic fatalities. And one issue that was noted during 2020 was that the number and percentage of vehicles traveling greater than 50 miles per hour over the posted speed limit increased. And so we saw a lot of people driving very quickly on roads and more concern about accidents at higher speeds. So just something to keep in mind when people are stressed, sometimes their foot gets a little bit heavier on the gas pedal. We also saw homelessness. And one of the interesting components of homelessness during COVID was there were some declines, at least in the way that we collect data on homelessness. We looked at individuals experiencing some kind of sheltered homelessness in rural areas. And again, what I mean by that is where there is a specific shelter where homeless people can go. We saw a decrease of about 4% of individuals, whereas we saw about a 10% decrease in families experiencing sheltered homelessness. But interestingly, about 21% of sheltered unaccompanied homeless youth were from rural areas. So there was a disproportionately higher percentage of rural homeless unaccompanied youth than we saw in from urban areas. And one of the things that is really interesting when we look at some of the challenges that we see in responding to homelessness is that homelessness doesn't necessarily look the same in rural communities as it does in urban communities. In part because a lot of our rural communities, we have no shelters. And so a lot of times people find themselves couch surfing or even sometimes sleeping in their cars or trying to find other types of shelter because there is no dedicated shelter for homeless people. And on the Prepare tool, one of our rural providers noted that as they were observing questions that were being asked, one of them was, "Are you homeless?" And nobody wants to admit they're homeless. And especially, during the public health emergency, for example, a lot of people ended up traveling together in cars for testing. If there was a big testing day, you might have 5 people in a car to get tested or vaccinated, depending on what the situation was. And so if people would ask everyone in the car, "Are you homeless?" and you happen to be that person who was, it was often uncomfortable to be able to say that you were homeless. There was a stigma with it. And so they reframed the question to say, "Do you have a safe place to live?" And then as they would speak, they would say, "Well, please tell me a little bit more about your situation." If something triggered them, for example, a hesitancy or a look, just to try to make sure that they were getting information that was important, as we do in motivational interviewing, so that we could identify or address what the problem or what the situation was and see if there were resources that could help the person. And one of the really important pieces of our value-based payment programs has been care coordination community health workers, where we have a lot of those community partners already engaged. And so a lot of our care coordinators and community health workers, they know what resources are and they know where to make those connections. And so they were able to leverage resources to assist some of the people in their community to locate safe accommodations. And for some people, this was the first time they have ever experienced challenges because they didn't have a job. They lost their ability to work and then had no paycheck. And so for some people, this was a whole new environment and they had no way to navigate. And so it was really helpful to get that support. They also were able to link patients to resources, including helping them to get some kind of unemployment if that was appropriate. And in a couple of different examples, they were able to help people who were affected by domestic violence get to a safe place. Likewise, one of our rural colleagues shared that there was a family that was living in a car in their community in the winter and with small children, and they were able to get that family to a neighboring community that had a homeless shelter, and they were able to get that family back on their feet. I was also told that it was important to make sure that there was supplies. Oftentimes when there's an economic downturn or people are unable to work, or they lose their job, their business closes or what have you, even getting things such as soap and toothpaste and things to help with hygiene can be a challenge. So a reminder is to think about all of those other pieces that also help people remain safe in their home, and if they are needing to go to live with others, that they can get supports and can get the supplies that they need to help them through that time. As I mentioned, social isolation was a challenge, and I like to reframe it saying social connectedness is more valued than ever. And again, those rural communities that were well connected with their community partners and were already sharing resources, were really good at looking at how they could expand those connections to assure that the people that they served were safe. And so they had neighbors checking neighbors. They had mail carriers identifying if mail hadn't been picked up, so that people would call and check in and make sure everything was okay. Likewise, they knew who the delivery people were, UPS and the like, to make sure that there were connecting with people, and if there were any issues that were creating challenges, that resources or help could be brought to bear. For older adults, technology sometimes helped, such as Zoom and FaceTime. In fact, I had a great call with a 103-year-old who told me that she has become quite adept at using Zoom. However, there were a number of other rural providers who shared that many older adults really struggled, and not having technology further isolated them, either because of poor broadband or perhaps not having an internet connection at home, or not having the technology or knowing how to use the technology, made it very different, or made it very difficult for them. In fact, I often tell the story, my dad has a smartphone, but he calls it his master phone because it really tells him what to do. And he appreciates having Siri help him through. One of the positives as well was after people were able to get vaccines, having outdoor gatherings and bringing people together in the warmer months really helped raise not only the spirits of the people that had been isolated, but also the family and caregivers who were able to also benefit from having those connections reinstated. So what might be some future directions? There are some really great programs out there that are further expanding the way we are able to connect our supports for social determinants of health to make a positive impact on the health and well-being of the patients that are served. And one of them is through our Medicaid and CHIP flexibility in addressing social determinants of health. There are state plan and waiver authorities that allow the ability to add non-clinical services to benefit packages, including different types of care coordination, care management, housing supports, employment supports, including some training. So those are a real positive way to be able to think about how social determinants of health may be able to be leveraged through Medicaid and CHIP. There's also a really new and exciting program in North Carolina called Healthy Opportunities Pilots. It just started in March. And this is a pilot that has 3 different regions, and they are going to encompass food, which started in March. In May, it's going to also open up to housing and transportation services. And in June, it will include interpersonal safety and cross-domain services. And so this is a program that I think a lot of states are watching to see how it unfolds and to see what ways other state Medicaid programs may either adopt or adapt to be able to meet the needs of the people that are served in their state. Medicare Advantage also has a program through the Chronic Care Act that also expands its ability to address social determinants of health, as well as looking at other types of alignment between value-based payment models and community-based organizations, particularly around areas of housing and food. And right now we're seeing some of this unfold in the Pennsylvania rural health model, in which they are leveraging their global budgets to be able to look at how they may do more community engagement with community-based organizations, as well as looking at what care coordination issues can be brought to bear in addressing the needs of the populations they serve to not only improve outcomes, but also to improve the quality of life for the patients in their communities. I also asked a question. I said, what is the best advice you could give when thinking about all that happened during 2020 and 2021 in responding, and hopefully now we're looking in 2022, recovering from COVID. And the most emphatic answer I received was, be kind. Be kind because you don't know where people have been. You don't know where people exactly are, and you don't know where they're going to be going. So be kind for the time, especially that you have with them, because you may be the light in the world that they have that particular day, and it may make all the difference in them being able to share what their needs are, as well as to identify what their goals are so that you can help them move along that Maslow's hierarchy to achieve their best health. As I said, we're on this road together. We don't know how high we need to climb to address these social determinants of health, but there are some resources that are available for you. We have our Social Determinants of Health in Rural Communities Toolkit that is available on RHI Hub. This toolkit provides information on all different types of programs. And like our other toolkits, this toolkit is developed in a modular format to meet rural communities and rural providers where they are. If you're interested in learning more about the topic, there's a great introduction. If you're already at the program model point and looking at how you want to think about addressing the social determinants of health, there are 5 different types of program models, as well as a program clearinghouse of where programs have been successfully implemented in rural communities, as well as information on implementation consideration, evaluation strategies, sustainability options, and also thinking about how to disseminate the great good work that you do so that your community also is aware of the resources as well as the achievements that you have made through your efforts. There are a total of 24 toolkits now available. And as I talked about, especially with value-based payment, we see a lot of care coordination. We see the use of community health workers, and we also see services integration. Those are key tools in addition to our transportation toolkit that really address a lot of those social determinants of health key issues. There are 2 toolkits in the works that will also be very helpful. This summer, we are launching a rural health equity toolkit that will provide some great ideas about how to implement programs as well as track progress, and also a health literacy. Because one of the things we've learned too through COVID is that a lot of people are learning how to use telehealth, for example. A lot of people are also learning more about how to take care of their health and to work as partners in maintaining their health and well-being along with their providers. So stay tuned. Those 2 toolkits will be forthcoming yet this year. We also have another great resource, the Rural Health Research Gateway, which is housed at the Center for Rural Health at the University of North Dakota. This Rural Health Research Gateway features many different research projects that are central to having an effective value-based payment program, and also addresses some of the programs that have successfully implemented social determinants of health. I am part of a Rural Health Equity Research Center that is a partnership between the Northwell Center for Rural Health Analysis and our partners at East Tennessee State University. So this is a wonderful resource. Both RHI Hub and the Rural Health Research Gateway is funded by the Federal Office of Rural Health Policy, and both are housed at the Center for Rural Health at the University of North Dakota. Last but certainly not least, taking care of rural health rock stars who take care of their communities is foundational to everything that we do. And I had the great opportunity of talking to Tony Ann Richard, who is the CEO of the Healthcare Collaborative of rural Missouri. She shared these takeaways. And given all the things that our rural health providers have been through this year and the past year, I thought it would be fitting to end with this takeaway. First of all, she said, establish an organizational culture that reflects its mission. If you want to be kind, make sure that your employees be kind. Take care of your own needs before assisting others. And we hear that every single time we're on an airplane. Make sure you secure your mask before securing others. Also, offer generous paid time off. It's important that people have a chance to recharge and renew. And they can also do that through implementing flexible work schedules, particularly because we've learned a lot about not only rural healthcare providers caring for others, but also the needs in their own family, their children with homeschool, with children who were quarantined during school and parents needed to be home with them, as well as many older adults that needed caregiving during the time of the public health emergency. She also mentioned that it's important to remind your staff about employment assistance programs. Sometimes our staff get overwhelmed. They've seen a lot of challenges with people being very sick, dear friends and community members dying, and just a lot of stress for a lot of people for a sustained amount of time. So her advice was to make sure that you remind staff that they have access to an employee assistance program. And she also said, take a health day if you need it. It's important for your good health that you need to be the role model. And if you need a day to attend to your own health, make sure that you take that day and make sure that you maintain your health and well-being. It's important to all the people that you serve. And most importantly, it's critical to you and your family. So with that, are there any questions? Looks like we have some in the chat. Let's see, I'll go up to the chat. Are there any questions that anybody has? if there aren't any questions, do any of you have any great examples? Here, why don't I stop this share? Do any of you have any great examples of experiences or solutions that your community has identified through this public health emergency?
Alana, this is Rhonda Barkus. I'll just share, I was doing a community health needs assessment and was meeting with a key stakeholder. And one of the things that she shared is that she had worked in a community where they had a social worker who could provide mental health services. And she actually spent her time at the food pantry. And so then when the families came in to get food, the kids could spend time with her kind of in some play therapy, just very informally. And it was a way to really address two issues at once.
That's an excellent example. That's a really important one. I know that there are a lot of concerns too about having adequate staff with some of the issues of, for example, the cost of traveling nurses and the like. And so have any of you heard or have any examples of how your communities have been able to address some of the staffing issues?
Before you had specifically asked that question, Alana, Brad from North Dakota had just shared that in North Dakota, he has seen a few more community gardens. And then for mental health specifically, they're seeing at least 4 CHA hires with an advanced practice nurse with MH background. And I see Stephanie has her hand up.
Yeah, I just wanted to say I thought this was really timely because I think as a flex and ship coordinator, one of the things I always struggle with is sort of how can I be better support for the critical access hospitals and the rural health clinics? And I feel like, at least in Idaho, one of the challenges is the data collection, even on the front end. I think there is an assumption a lot of times when they're collecting data, they don't really even pay attention to some of the diversity that may exist within their communities. And so, we don't have a lot of resources when it comes to the data analytics, and you don't have a whole lot of resources with even the folks collecting the tools, right, or collecting the data from the beginning. So that Prepare tool, I know our federally qualified health centers are very good at leveraging that. And they are really good with data collection. So I was talking with the Hospital Association about this, and we are working together to try and figure out how to talk about that social determinants of health data collection on the front end in the ED. So that Prepare tool is very timely. And I just wanted to say thank you. I don't know how difficult it is to implement on a CAH side of things in the ED, but I am certainly going to give it the old college try because we're just struggling to figure out, staffing is a huge issue anyway, but if you're going to be doing this, you might as well be trying to collect the right data on the front end and then seeing how you can leverage it on the back end. But for us, we're still even stuck in that data collection piece because there's too many assumptions right now that they just kind of lean on rural as being the area of maybe the vulnerable population and the underserved and that sort of thing, but they're not even really peeling back all the layers of the onion for their communities that are there. So thank you.
Absolutely. And after this call, I'll work with Kiona. I have a couple of people. I'm going to just double check and make sure it's okay that I share their contact information far and wide, but they actually have experience implementing, embedding the Prepare in their critical access hospital ED in the EMR.
Wonderful. Oh my
So
gosh, yes,
we
thank
can
you.
Connect those dots for you.
Perfect. Thank you so much. I appreciate it.
In the chat box, Alana, Brad had just shared also from North Dakota that for specifically around staffing, at this point, they're just trying to survive. So right now in rural North Dakota, staffing, particularly nursing, is their main concern.
Well, and you know, I have to tell you, even in the Washington Post, there have been a number of articles about caregiving and about how many, especially women, who have given up their employment to either take care of children or to take care of older adults in their family. And part of that is they can't get in-home, you know, even trying to get in-home CNA support or any kind of home health support has been really, really challenging. So I can only imagine that's a huge need as well in many of our rural areas.
Rhonda just shared that perhaps not specifically a new idea, but more hospitals are bringing back LPNs rather than staffing only the RNs or CNAs. We're welcome to continue asking questions, or if anybody has any further comments that they would like to share. But in the meantime, before we close up, because I know we're coming to the top of the hour, I have posted the post-polling questions, and if you could take time to answer the 4 questions, we'd greatly appreciate it. It's going to help us measure the knowledge gained throughout today's presentation, as well as your satisfaction within today's webinar.
I was also going to mention the Centers for Disease Control. They are also sponsoring another new web-based toolkit that will be available on RHI Hub sometime late this year, and it's on preparedness and planning. And so again, it isn't just for public health emergencies. We're looking at all disasters, since our rural communities have been faced with everything from chemical spills to wildfires to tornadoes. And we are working closely with the state offices of rural health, with Flex, and with other rural partners to ensure that we are calling together all of the best practices that are out there. And if you have any additional thoughts or experiences regarding responding or recovery, we would greatly like to hear from you as well. So please know that we also welcome learning from you. So thank you.